Hi, welcome to another episode of Scaling Vision podcast. Today we have with us a very great personality, Dr. Parimal Deshpande. He's an interventional pulmonologist at the KRIMS Hospital. Welcome to the podcast, sir.
Thank you.
I want to discuss with you, sir, how pulmonology works. Different aspects of different lung diseases or disorders. Then we'll slowly take up newer advances in treatments. I think lung transplant is a new big thing nowadays. We'll talk about that. How to prevent all these things, we'll slowly take it up. I want to start with you briefly telling us about your background and how did you become a pulmonologist?
It's a long story, but cutting it short, I was just a medical enthusiast a few years ago. I decided to go to a medical field. I joined Lata Mangeshkar Hospital. I did my MBBS over there. Then certainly I wanted to do specializations, and by that time I was quite naive. The only thing I wanted to do was a specialization in certain field. So I chose lungs as my domain. It was not by default. It just happened. Because when you tend to go into the medical field, you tend to explore few things. You tend to know few things, and over a period of time, I thought, what does life define? It's basically a philosophical thing. How do you define life, and how do you define a death? It starts with a breath and it ends with a breath. So why not deal with a condition where we can improve breaths of breaths of patients? So it started like that.
So what does a typical day of a pulmonologist look like, sir?
It's mundane. It's routine. Waking up, going to the OPD, looking after the patients who are having a difficulty in breathing. Typically patients are having asthma, COPD, interstitial lung disease. We deal with pneumonias. They come here. Then we have medical emergencies, pulmonary emergencies basically, which we deal. Then there are obviously critical care attached to it. Whenever respiratory comes, there comes a respiratory failure, and whenever respiratory failure comes, there comes ventilator.
Right.
So complex ventilatory settings, you deal with it, and then obviously we have the procedures: bronchoscopy, thoracoscopy, EBUS, and obviously the higher end cryobiopsies and all that. Then subsequently again OPD, and then coming back to home and taking all the reports of whatever we are done. It's a mundane thing.
Right. For the people who don't know about this, what does pulmonology involve, and what are the routine diseases and disorders that people should be aware about regarding their lungs?
Simple. Whenever we take a breath, it starts from the nose and ends up into the lungs, and technically we call it as alveoli. So leading from the nose till the very end, whatever, if at all any disease, anything happens to this, we deal with it. So right from starting from the nose, we deal with the allergies. This is called as allergic rhinitis, then pharyngitis, then airway diseases like asthma, COPD, then parenchymal diseases like pneumonia, tuberculosis. Pneumonias can be viral, infective, or infective involves viral, fungal, bacterial. And then obviously pleural diseases are there. The pleural effusions means fluid accumulates in the pleural space between the chest and the lung. We routinely deal with those kind of things. And newer entities like interstitial lung disease, which is very well known right now. And interstitial lung disease is quite a new thing. There are enough evidences to show that industrializations and many lifestyle changes have triggered interstitial lung disease, and it's a nascent disease, but we are exploring over it, and it is underdiagnosed, and we deal with those.
In a city like Nagpur, sir, what are the most common people and things that walk into the regular OPD? Majority, like I'm sure asthma तर असेलच, पुढे अजून काय?
बरेचसे पेशंट्स कसे असतात ना की त्यांचं डायग्नोसिस झालेलं नसतं. ते आमची फील्ड टर्शरी फील्ड आहे बेसिकली. तर लंग्सशी रिलेटेड ज्या गोष्टी असतात, जसे अस्थमा, COPD, इंटरस्टिशियल लंग डिसीज जसं मी बघितलं म्हणजे बोललो आता, इंटरस्टिशियल लंग डिसीज हा ना खूप मोठा एक असा ग्रुप आहे जो अंडर डायग्नोज्ड आहे आणि त्याला डायग्नोसिस करायला भरपूर वेळ लागतो, कारण की हा नवीन आजार आहे आणि त्याच्यावर होणारे जे इलाज आहेत ते पण नवीन आहेत आणि त्याला लागणारे डायग्नोस्टिक मोडॅलिटीज त्या पण नवीन आहेत. पोस्ट कोविड त्याच्याकडे लक्ष पुष्कळ गेलेलं आहे आणि असं जाणवलं की हा इंटरस्टिशियल कंपोनंट खूप जास्त आहे. जसं सिम्पल एक गोष्ट सांगतो की संधिवात ज्यांना असतो त्यांना इंटरस्टिशियल लंग असण्याचा खूप एक मोठा चान्स असतो, पण ते संधिवात असलेल्या पेशंट्सला लंगची कंडिशन जाणून घेण्याची.
इज इट ऑटोइम्युन म्हणजे?
येस, ऑटोइम्युन दॅट इज समथिंग कॉल्ड एज CTD ILD, कनेक्टिव्ह टिश्यू डिसऑर्डर रिलेटेड ILDs. म्हणजे ऑटोइम्युन प्रोसेस टेक्स पार्ट आणि ऑटोइम्युन अफेक्ट्स युअर किडनीज, लिव्हर, your interstitial, wherever there is interstitium it affects, it does affect lungs also, आणि त्याच्यात इंटरस्टिशियल लंग डिसीज होतो. तर हे नवीन मोडॅलिटीज आहे आणि त्याच्यावर राहणारे जे डायग्नोस्टिक मोडॅलिटीज आहे ते आता सुरुवात झाले आहेत आणि आता एक असं विजन झालेलं आहे लोकांचं, फिजिशियन्सचं, की याच्याकडे आपल्याला लक्ष द्यायला हवं.
सो व्हॉट हॅपन्स सर की लेट्स से अ पेशंट गोज टू अ जनरल फिजिशियन अँड युजली ॲलर्जीज असते, कफ कोल्ड, नॉर्मल प्रिस्क्रिप्शन इज गिवन. Let's say it is not being able to manage by general physician, more it gets referred to a pulmonologist. Probably this is what I'm thinking. Course of events होत असतील directly तुमच्याकडे न येता there must be a certain portion of patients which are referred to you, right?
Correct. I got your point. It's a very good question. See, patients are a bunch of I say individuals are having symptoms. They first referral, obviously they go to physicians. It is the very basic thing that they go to physician with a certain set of problems. After that, it is the physician who filters it. Right. Physician filters it, it can be treated at a primary level or it requires a tertiary level setup. So obviously, first referral is from the physicians. They refer to us when they feel that it needs a pulmonologist. Secondly, there is quite awareness among educated people. There is YouTube, there is Google. Once you have some certain kind of symptoms, you tend to visit to pulmonologist in our setup basically. I will give you an example. If you are snoring, it's a normal thing. But if you are snoring and your sleep is hampering, there is something called as obstructive sleep apnea.
Right.
Many people come to us directly without referring to a physician because they know, they are aware about their health.
They've done their Google search.
Yes.
Right.
Google search, and they land up with a pulmonologist. But primarily it is the physicians who refer to us.
Let's talk about, sir, the most common thing that everybody is aware about, asthma. Talk us about bronchial asthma, different types of asthma, why it is happening, incidences, allergic bronchitis, all those things. Walk us through all of them.
Asthma is a very broad topic.
Right.
Firstly, it's a disease of an airway. Secondly, it's a reversible thing. By definition, asthma is a reversible thing. Sadly and unfortunately in India, it is underdiagnosed. It is undertreated, and most importantly, there is lack of awareness. There are beliefs, there are n number of terminologies like childhood asthma, baaldama, and n number of terminologies, but ultimately it's a swelling and hyperresponsiveness of airways. What we call it is as allergic bronchitis, or if it is severe format, it is a bronchial asthma. So to call it as a bronchial asthma, you need to have certain things which are very very closely related to the disease per se. That is, you need to have some wheezing, shortness of breath. Then you might be having persistent cough. There might be a seasonal variation. With the change of every season, the symptoms get exacerbated, and there is a diurnal variation, what we call as this. Some symptoms are quite aggressive in early in the morning rather than in the afternoon, and obviously it gets triggered by few things like dust, smoke, or certain kind of foods. And these people, asthmatic people, they usually have a genetic history. Or they live in a polluted state, or they have any allergic form of conditions like atopic dermatitis or some kind of eczemas and all skin related problems. These are category of patients. If they are having a shortness of breath, wheezing, diurnal variation, or seasonal variation of the symptoms, most likely they have asthma, and for which they need to get evaluated. with a simple test called as a pulmonary function test, and where we can document the reversibility and the FEV1 FVC ratios, which suggest that patient is having either a bronchitis, bronchial asthma, or COPDs. So this is how it is.
I remember FEV1, FEV4
Yeah.
is expiratory volume.
In
physiology.
one sec.
Right. Let's talk about COPD,
Yeah.
pneumonia, one by one.
See, right now we briefly talked about asthma. Now, COPD is slightly different thing. It is a disease of an airway as well as a parenchyma. What generally in layman term, what happens due to any noxious stimuli, due to pollution.
Let's switch to Hindi for this one.
हाँ, COPD एक अलग ही क्षेत्र की बीमारी है जिसमें एयरवेज इन्वॉल्व है, लेकिन ये बीमारी कुछ नॉक्शियस स्टिमुलाई से, जिसे हम नॉक्शियस स्टिमुलाई बोलते हैं, उससे ट्रिगर होती है.
Right.
जैसे कि प्रदूषण है, स्मोक है, स्मोकिंग फर्स्ट हैंड स्मोक हो सकता है, यानी आप सिगरेट बीड़ी का सेवन खुद करते हो, या पैसिव स्मोकिंग होता है, या कोई आपके आजू बाजू के व्यक्ति अगर स्मोकिंग करते हैं तो वो स्मोक अंदर जाने से भी ये डिसीज हो सकता है. या थर्ड हैंड स्मोक होता है जो बहुत लोगों को पता नहीं होता है.
Third hand smoke.
Third hand
This
smoke, yes.
this is new.
This is a new term.
Right.
But it happens everywhere. Like if I am smoking, it's a first hand smoke. अगर मैं स्मोक कर रहा हूँ और मेरे साइड में जो व्यक्ति है वो सेकेंड हैंड स्मोक होता है. लेकिन मैं जो एरिया में स्मोक कर रहा हूँ, वहाँ के जो कर्टन्स है, वहाँ के जो दीवारें हैं, वहाँ के जो वो एक पर्टिकुलर एक कैच करते हैं स्मोक, और वो एरिया में अगर कोई चौथा व्यक्ति आ जाए और वो स्मेल करे तो दैट इज थर्ड हैंड स्मोक. सिंपल है. अगर आप कार में बैठ के अगर स्मोक कर रहे हो और अगर आप एसी चला रहे हो तो आपके कार के सीट के कवर से भी दूसरे दिन स्मेल आता है. व्हाट इज दैट? दैट इज अ थर्ड हैंड स्मोक. सो इवन थर्ड हैंड स्मोक हैज बीन एट्रीब्यूटेड टू COPD.
But it is so less.
Yes, it is slow. It is very less. But अगर आप continuously over a period of exposure delayed period of time आप लोगे तो आपको दिक्कत होगी. ये बेसिक ये चीज़ है. वही हमारे पास बहुत सारे पेशेंट्स आते हैं और वो बोलते हैं कि मैं तो दिन का तो एक ही सिगरेट पीता हूँ, तो मुझे कैसे COPD का चांस है. नहीं, एक सिगरेट भी हानिकारक है. और सबसे दुर्भाग्यपूर्ण जो हमारे भारतवर्ष में ये एक है, सदियों से चलते आ रहा है, जो कि काफ़ी अंडर डायग्नोज्ड है, वो है बायोमास फ्यूल एक्सपोजर. लकड़ी का चूल्हा, कोयले का चूल्हा, या कोई भी प्रकार का चूल्हा घर पे जलाना जिसके ऊपर खाना बनाने का या पानी गर्म करने के लिए इस्तेमाल करता है, इट इज इक्वली डेंजरस है.
मोस्टली इट इज द घर की जो फीमेल रहती है,
करेक्ट,
उनको ज़्यादा सफ़र करते हैं.
बिल्कुल,
है ना.
मैक्सिमम पेशेंट जो हमारे फीमेल आते हैं वो तो कभी स्मोक नहीं करते, ना फर्स्ट हैंड, ना सेकंड हैंड, ना थर्ड हैंड. उनको क्यों होता है? हिस्ट्री अगर आप निकालें तो आपको पता चलेगा वो बचपन की उम्र से 20 साल की उम्र से वो खाना पका रहे हैं और वो लकड़ी के चूल्हे पे गोबर के इसके चूल्हे चलाते हैं जिसकी वजह से स्मोक होता है. तो बेसिकली मैंने जैसे कहा कि नॉक्शियस स्टिमुलाई जो होता है वो कुछ भी हो सकता है. वो इंडस्ट्रियल पोल्यूशन हो सकता है, वो बायोमास फ्यूल एक्सपोजर हो सकता है, वो सिगरेट स्मोकिंग हो सकता है, फर्स्ट हैंड, सेकंड हैंड, थर्ड हैंड स्मोकिंग कुछ भी हो सकता है, या फैक्ट्रीज़ में काम करने वाले. जैसे चंद्रपुर एरिया में WCL है, वहाँ पे काफ़ी कोयले की खदान है, वहाँ पे जो मजदूर काम करते हैं या कोई रिलेटेड सुपरवाइज़र और या रिलेटेड इंडस्ट्री में काम करते हैं, वो कंटिन्यूस एक्सपोजर होते हैं. सीमेंट इंडस्ट्री वाले एक्सपोजर होते हैं, डाई इंडस्ट्री वाले एक्सपोजर होते हैं, उनको COPD होने के बहुत ज़्यादा चांसेस होते हैं. बेसिकली इसमें क्या होता है, जहाँ पे
wouldn't that be silicosis, asbestosis?
नहीं, वो तो काफ़ी हाई एक्सपोजर की वजह से हुआ है. जस्ट नॉक्शियस स्टिमुलाई ओवर अ पीरियड ऑफ टाइम क्या करता है कि जो अंदर में हवा जाती है वो फिल्टर होती है लंग्स में. लंग्स एक फिल्टर है जहाँ पे ऑक्सीजन अंदर जाता है और कार्बन डाइऑक्साइड बाहर आता है. तो ये नॉक्शियस स्टिमुलाई जब जाता है ना, तो ये जो फिल्टर है, ये फिल्टर को डैमेज करता है. तो उसमें एग्जैक्टली जो एबिलिटी ऑफ लंग होती है वो खराब होती है. क्या? ऑक्सीजन अंदर लेना और कार्बन डाइऑक्साइड बाहर फेंकना. तो उसमें क्या होता है, शरीर में ऑक्सीजन कम होता है और कार्बन डाइऑक्साइड बढ़ता है, और जो लंग्स की ओवरऑल इलास्टिसिटी होती है वो कम हो जाती है. तो दैट इज वेयर वी कॉल्ड एज एम्फाइसीमा. जहाँ पे फिल्टर होता है वो डैमेज होता है, उसको एम्फाइसीमा बोलते हैं. और जो पैरेनकाइमल जो होता है वो स्टिफ होना शुरू हो जाता है और वो इलास्टिसिटी लूज करना शुरू करता है. तो इसको बोलते हैं COPD. COPD का नाम है क्रॉनिक ऑब्स्ट्रक्टिव पल्मोनरी डिसीज.
इज इट रिवर्सिबल?
नो, सैडली इट इज नॉट रिवर्सिबल. इट इज प्रोग्रेसिव डिसीज, एंड विथ एवरी इन्फेक्शन एंड विथ एवरी ट्रिगर लंग की कैपेसिटी 5 से 7% कम होती है। तो मान लो अगर आपको साल में एक एग्जासर्बेशन आ जाए, इन्फेक्शन से हो या नॉक्शियस स्टिमुलाई से हो जाए, सीओपीडी डायग्नोस पेशेंट को 5% यदि कम हो रही तो 10 साल में तो उसकी 50% से भी कम हो जाए।
वेरी ट्रू। सर ब्रीफली,
निमोनिया कुछ भी नहीं है। निमोनिया एक लंग के ऊपर आने वाली सूजन है, न्यूमोनाइटिस। बेसिकली निमोनिया लंग के ऊपर एक सूजन है। सूजन किसी वजह से भी हो सकती है, ये बेसिकली इन्फेक्शंस की वजह से हो सकती है। इन्फेक्शंस कोई भी हो सकता है, वायरल, बैक्टीरियल, फंगल या ट्यूबरकुलस। और हालांकि ये निमोनिया टर्म काफ़ी बढ़ गया पोस्ट कोविड, लोगों को पता चलने लग गया कि निमोनिया होता है। अपने देश में टीबी की संख्या ज़्यादा थी, लेकिन कोविड ने ये परिभाषा को चेंज कर दिया, जहाँ पे निमोनिया, वायरल निमोनियाज काफ़ी आगे। अभी लेटेस्ट चाइना में चल रहा है जो ह्यूमन मेटान्यूमो वायरस, जो कि काफ़ी सालों से है, लेकिन अभी वो उभर के आया है, लेकिन वो ज़्यादा सीवियर नहीं है। तो वायरल इन्फेक्शंस काफ़ी आगे बढ़ गए हैं निमोनिया के। तो ये बेसिकली इसमें खांसी आना, छाती में दुखना और तेज़ गति का फीवर आना, ये चीज़ें होती है। और तीव्र गति में ऑक्सीजन कम होना, रेस्पिरेटरी रेट बढ़ना, बीपी कम होना, ऐसा हो सकता है।
ट्यूबरकुलोसिस,
ये तो एक बहुत बड़ा
ट्यूबरकुलोसिस
इंडिया ट्यूबरकुलोसिस एक थर्ड वर्ल्ड डिसीज़ माना जाता है, जहाँ पे अफ्रीकन कंट्रीज़, इंडियन कंट्रीज़ और एशियन कंट्रीज़ लाइक चाइना में ही पाया जाता है। ये तो काफ़ी बड़ा विषय है। टीबी एक ऐसी बीमारी है जो कभी भी किसी को कभी भी हो सकती है, फ्रॉम हेड टू टो इट कैन अफेक्ट। एक ऑन लाइटर नोट हमारे इसमें बोलना भी है कि टीबी कैन कॉज एवरीथिंग एक्सेप्ट प्रेगनेंसी। सो बेसिकली इट पॉइंट ऑफ एंट्री फॉर ट्यूबरकुलोसिस इज लंग। तो बेसिकली ऐसा समझ लीजिए कि टीबी के जंतु नाक के द्वारा फेफड़ों में जाते हैं, घर बनाते हैं, वहाँ पे बढ़ते हैं और वो शरीर में कहीं पे भी फैल सकते हैं, डायरेक्ट कांटेक्ट से या ब्लड के द्वारा फैल सकते हैं। और अलग प्रकार के टीबी कॉज कर सकते हैं, जैसा बोन टीबी, एक्स्ट्रा पल्मोनरी टीबी, पेट का टीबी, ब्रेन का टीबी, स्पाइन का टीबी, आपके ऑफ्थेल्मिक टीबीज भी होते हैं, जेनेटो यूरिनरी टीबीज होते हैं। टीबी एक लीडिंग कॉज है इनफर्टिलिटी का। स्किन टीबी भी होता है। इट कैन कॉज एनीथिंग फ्रॉम स्किन टीबीज टू बोन टीबीज, एवरीथिंग, बट एंट्री पॉइंट होता है लंग्स। सो अगर लंग्स में आता है तो वो बहुत आसानी से ट्रीटेबल है। और बेसिकली इसमें कॉन्स्टिट्यूशनल सिम्टम्स वही होते हैं। ये बेसिकली एक प्रकार का निमोनिया है, जिसमें खांसी आना, बलगम गिरना, बलगम के साथ में खून आना, वेट लॉस होना, रात को बुखार आना या बुखार जैसा लगना, भूख नहीं लगना, वज़न कम होना, सिग्निफिकेंट वज़न कम होना। और सबसे इम्पॉर्टेंट चीज़ जो होती है कि खांसी यदि 14 दिन के ऊपर है, 14 दिन से ज़्यादा आपको खांसी आ रही है और उसके साथ में बलगम आ रहा है और वेट लॉस और फीवरिश फीलिंग आ रहा है, तो उसको डायग्नोसिस करना चाहिए और टीबी का सस्पेशन जनरली होना चाहिए।
दिस इज अ क्वेश्चन फ्रॉम एन ऑफ्थेल्मिक पर्सपेक्टिव कि टीबी में सर वी सी AKT इज स्टार्टेड एंड वी ऑफन सी समहाउ, आई गेस इट इज मिस्ड एट टाइम्स, पेशेंट्स कम टू आर OPD विद अ लॉट ऑफ इथेनब्यूटल टॉक्सिसिटी. Has the treatment changed, or is there some way कि ethanbutal has been withdrawn nowadays, कि it's still given rampantly?
Sadly, as I told you earlier, TB is known as a third world disease. So research work is very less. Fundings is quite less, though it is increasing. From the 1947 streptomycin was introduced, hardly we have 5 drugs. Recently we have got 2 more drugs, bedaquiline and delamanid. There are few in pipelines, but it is at very slow pace. Sadly, for ophthalmic TB or any other TB, there are primarily only 4 drugs: rifampicin, isoniazid, ethambutol, and pyrazinamide.
Right.
And it has got many toxicities, but these are the only resources we have. In ophthalmic, particularly in ophthalmic TB, if ethambutol toxicity is there, the only thing we need to do is to shift only to three drug regime.
What we get to see in ROPD, sir, the patient comes with ekdam decreased vision. There is no ophthalmic manifestation. The fundus is absolutely clear. We do see a little bit pallor of the disc, which is suggestive of some kind of neuritis, which ethanbutal causes. Color vision drops, contrast sensitivity decreases, and basically the first complaint is मला काही दिसत नाहीये. And then we do a field test, we do a chart the field, we do a perimetry, basically we chart, and then we figure out that there is a loss of field. Now a loss of field for ethanbutal toxicity is a very typical. Any ophthalmologist can make it out कि हाँ ये probably ethambutol toxicity है with decreased contrast sensitivity and color vision. Then we write a note to the concerned pulmonologist or treating physician. इसका ethambutol please shift करो, and then we start some research papers where it is given high dose of vitamin B, multivitamins can probably cause a reversal. But this is how it is going to go about. I think there is no change coming, right?
Yeah. Sadly, there needs to be research done for there is a scope for new drugs, and you will be surprised there is no IV drug per se. For TB, we have n number of chemotherapies, we have n number of vaccinations. We don't have vaccinations for TB, we don't have even an IV drug for TB. So it becomes really difficult to treat, and that is why these cases of TB are not getting firstly diagnosed per se and then getting treated properly. Though government has taken quite initiatives and providing everything for free, but the research work is lacking.
Okay. Currently, we are seeing, sir, in a lot of, let's talk about India only, कि air quality has been deteriorating for various factors. What problems does it cause, a deteriorating air quality? What should people do to make sure that we don't get affected by it? And yeah, let's just talk about it.
See, sadly, smoking is my choice. Second-hand smoking is my choice. Third-hand smoking is my choice. But breathing is not my choice. The quality of the air which I breathe is not in my hands. It is the industrialization, it's a byproduct of industrialization, I agree. But what option do I have? Even if I put an air purifier at my home, that is not going to guarantee. I need to have a good quality air. If I breathe this quality of air which is an inferior, I'm prone to have diseases like COPD, which I told you, because it's a noxious stimuli which goes inside and causes damage to my lungs. So you will be surprised that out of the COPD patients, I have a data at my place, my tertiary center. It's a tertiary center where we have analyzed. You will be quite surprised to know that out of the 100 patients, 27 patients of COPD have a history of smoking. And what about 73? They don't smoke.
They don't smoke.
They breathe high,
this polluted air.
Polluted area. They reside in high polluted area. They breathe air which is very, very inferior to a human health. Sadly, 73% of population don't smoke. Yet they'll end up in COPD. What choice do I have?
So what is the advice to some people? Should you wear mask when you go out?
No, you cannot. You have to curb industrialization. That's it. This kind of AQI is not good for your lungs. Simple as that. Prime example is Delhi. They're shutting it down.
1900 AQI, sir.
Whatever. It is not.
Some of the machines were not even calibrated to even read that much of an amount of an AQI.
So the amount of inferior quality air which I am consuming is way beyond the industrial standards or the world standards.
Yes.
So industrialization, I am totally for it, but need to find solutions.
Sustainable way, probably.
That's what I call. It's not about my choice. It's not a choice. Breathing a good air is not a choice. And by this data, you will be surprised that I'm no longer promoting smoking, but I'm telling you the data. As I told you, even the simplest of measure, biomass exposure to a female in a village causes COPD. Chula, it's a dangerous, anything which creates smoke, and if you are taking inside, it's going to harm your lungs. Simple as that.
So what is the solution, sir? मुझे ठीक है वो policies change होगा, that these things happen at a glacier level. तब तक we as general population, what can we do at our level to at least mitigate some of those problems?
It's a fantastic question, and it's not known to even many physicians also. Get your pulmonary function test done yearly. Simple as that. If you see a drop in your pulmonary function test, that's an early indication that you might land up in COPD. What's the point in living in a city where your lung function is dropping at a younger age and you are still continuing over there? But awareness is very, 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 very less in our country. people go up with high-end procedures like ECGs, 2D echoes. They will do all the body checkups, but they won't do a PFT. So I suggest everyone who is living in a metro or whoever who has a family history to go for a PFT.
Very scary scenario, sir. Let's move ahead. Let's talk about allergies. Nowadays, I'm seeing a lot of children also coming up with early allergies, lung allergies, sneezing, wheezing. I get to see in my ophthalmopedies. I have to tell them कि जरा go किसी को दिखा के आओ करके. What's happening, sir?
See, allergy is a broad subject. Anyone, anytime, anywhere can get an allergy. So there are n number of allergens in lakhs and crores of allergens are there. So I will give you an example. Someone is having a pollen allergy. How many plants are you surrounded by? Lakhs, crores. You don't know whom you are allergic to.
Right.
Secondly, some people are allergic to foods. Basically, gluten is a big thing. Some are lactose intolerant. Then they are allergic to other food conditions. And third is, which is very common in our practice, is a dust allergy. It's not actually a dust allergy. It's an allergy to the dust mite. The dust mite allergy is very common and it's very hard to treat because dust is everywhere. And wherever there is a dust mite. And dust mite allergy is common and that can lead to sneezing, wheezing, runny nose, and any kind of exacerbations of allergies which can lead to bronchitis and all that. Primarily, allergy is dependent on the ecosystem of our body. The good the ecosystem is, it will fight any kind of allergy. Simple example, if 10 people go and they are exposed to dust, 9 out of 10 will have a sneezing, cough and all that, but the 10th guy will have this cough, sneezing and all that, but it will have a very aggressive form of that. That is what allergy is. Allergy is an hyper-responsive to a noxious stimuli or an allergen. So it depends on the person to person, and these industrializations and over a period of a time, allergens have increased. It has not decreased. And I told you, it's all tinkering with the nature and which is causing us to deal with all these kind of things.
COVID. What is the key takeaway that we all can learn from something like COVID? And what are some long-term changes in health delivery that happened?
COVID, I just wish it doesn't happen again. It was a nightmare. It was something which made me realize, once again I'm going philosophical, that life is very short. As they call it, kal ho na ho. The moment I went to OPD, either I was dealing with a patient who is landing upon ventilator or young patients landing upon ventilator, or I was signing death certificates for that. So it was very, very bad experience. What it taught me, that you should be prepared for anything. We were not prepared for it. Now we are prepared for any kind of emergencies. Second, the role of vaccination, the role of preventable diseases like influenza. I am telling you, in spite of the COVID pandemic, many people still are not aware about vaccinations for other diseases like influenza, which is potentially life-threatening disease, preventable disease with a vaccination, with a one shot of vaccination. People don't do that. I just wish everyone gets vaccinated every year.
Who should get an influenza vaccine?
Anyone.
Above what age, and how many times a year do we need to take a booster?
Anyone who is above 1 year of age should get vaccinated every yearly with influenza vaccine. It's quite cheap, it's not costly, but awareness is not there and the willingness is not there. And everyone should get vaccinated because it's a highly preventable disease and it's a potentially life-threatening disease. It causes lung fibrosis. Many of them even die because of influenza, but it can easily be prevented.
COVID may you must have dealt with a lot of consultations, remote. Some people who, I mean, what I'm trying to talk about is COVID basically changed a few healthcare का कुछ चीजें बदल दिया उसने.
Yes.
New things.
Definitely, because of the lockdown and all that, policies changed and the online consultation increased exponentially.
Acceptance आ गया बहुत सारा.
acceptance and always legality.
On the both sides.
Legality. Government made it legal to have an online consultation. Giving an online prescription also became valid. So it became a norm, and which is a good thing for our country like this, where people in remote areas don't have an access to a say specialist per se, and it has opened a streamline for another high-end procedures like lung transplantations. Lung transplantation was very naive pre-COVID era, but post-COVID era, many of the young patients had lung fibrosis and which were left with no other option but to transplant. And it was started with COVID, dealing with the post-COVID fibrosis. Now it has been extended to many other diseases. So COVID has changed the lung transplantation thing for the good, I guess.
Throw some light on lung transplantation, sir, please.
See, lung transplantation is a high-end procedure where basically when no other option is left with you, the patient is subjected to lung transplantation. It is very similar to a renal transplantation. Like patient who is on dialysis, and when the dialysis doesn't work, is subjected to a renal transplant. So basically a patient who is say a high end stage lung disease of COPD, interstitial lung disease, or post-infective fibrosis is on supportive oxygen for many days, and there are other criteria to judge it, is a candidate for lung transplant where a donor lung is transplanted to a unhealthy lung patient, and it's a new end, and it's in a nascent stage, I must say. It's in a baby step we are taking towards lung transplantation, but it is working, and results are good, and it's quite promising, and the future is promising, and the vision towards lung transplantation has evolved post COVID era. Certainly COVID has given a fillip to it.
Nowadays, sir, we are seeing those stem cell therapies, and we are seeing 3D printing of lungs happening and 3D printing of livers happening. We have 3D printing of cornea, stem cells. Somebody is growing heart. Do you think CRISPR and all those things? Do you think
stem cells it hardly works in lung conditions, but yes, research work is going on for interstitial lung disease, and also for COPD. Stem cell transplantation is going on, but the new thing is putting a graft from a donor to a recipient, and going forward it is going to get evolved.
Let's come to a lifestyle choice that people have made. Smoking, tobacco. Let's talk about this. Some people take it to so extreme levels that it causes cancers and everything goes down the drain. Walk us through all those things, sir.
Simple. Smoking is not only dangerous, it ruins your life. There is no criteria which suggest that X amount of smoking is dangerous and less than that is less dangerous. Even smoking one cigarette is same as smoking 100 cigarettes. Only thing is, if you are smoking 100 cigarette, increases your probability of getting disease earlier.
Right.
It doesn't mean you won't get disease. See, got a point. If you are smoking one cigarette, you will end up in a disease. But if you are smoking 100 cigarettes, you will get it earlier. Very simple as that. Right, so no fun in smoking. And as I told you, even a second-hand smoke is dangerous. So why the hell are you putting yourself for a smoke?
Do you see, as a pulmonologist, do you see a lot of tobacco misuse patients coming, or that goes to oral surgery guys?
Chewing tobacco primarily doesn't cause pulmonary disease per se. It causes oral cancers and all that. It's a smoke. It's a tar. It's all the noxious gases which comes out, like carbon dioxide and all that, which comes from a smoke. It hits your alveoli. It hits very hard and it destroys it.
What are some lifestyle changes that people should do suffering from chota heart condition, lung conditions, where they can kind of try and have a better lung health?
3 things are very important for maintaining a lung health. First thing is you should avoid any kind of smoke, biomass fuel exposure, or pollution at any cost. These are non-negotiable things for a lung. Second thing, you need to have a healthy lifestyle, reduce the weight, assessment of your lungs third is very important. Get yourself checked yearly for your lung status, so that you will be aware that am I in a good lung health, or my lung health is deteriorating or not. And fourth, most important, which I would like to reiterate, is get yourself vaccinated. There are preventable diseases which can go with a simple shot of vaccine. Why not do that? You should do that.
कितना simple है, एक इंजेक्शन ले लो, विषय संपला.
Yes.
Right? Tell us some about any memorable patients that you have had over the years. Tell us some stories.
There was a lady way back in COVID era. It brings back to me because COVID was a highly emotional thing. जहाँ पे पता ही नहीं था हम खुद सर्वाइव करेंगे या नहीं करेंगे. ठीक है. This lady was a 92-year-old. She came and she was on ventilator. She was put on ventilator. I did put her on ventilator, and she was 22 days on ventilator. And she came out.
92 years.
92 years she came out. It was a big thing. And the first thing what she did, she asked me, where am I? I thought I was gone. I said, you are in hospital, you are doing fine, and I might discharge you. And by the way, I discharged her over a period of time. But she said, what's the point in putting me on ventilator? This ventilator you should have given to a younger patient. That kind of melted my heart. And that was a life-changing experience for me. Because what I felt, at the end of your life, you believe in giving others rather than taking for yourself.
Definitely.
So that is a lesson which I thought, and that gave me an inspiration to do more work. Because as I told you, early in the morning after a cup of tea, I was dealing a patient on ventilator, or I was signing a death certificate. And here comes an old lady who came out of ventilator and saying that, give my ventilator to someone deserving, not me.
Right. Very true. How do you deal with death? You must have seen a lot of death so closely, and these were bad deaths, it takes an emotional toll on you as a doctor. How do you make sure that this doesn't affect you when you go back home?
Medical training is as such that you become ruthless, emotionless, and you deal with the problem as per se.
You are somehow able to detach yourself.
Yes, but somewhere down the line, you tend to analyze that life is very uncertain. You never know, as I told you, kal ho na ho. Live life to your fullest, and you certainly cannot take your life for granted, and certainly you should not waste the good life which you have got. You have got a good organs. Don't destroy it with your own will. It's in your hands. Whichever things is not in your hands is obviously not in your hands. Like a COVID was not in your hands. So why you want to destroy a good health of yours?
Right. Let's do a quick roundabout. Sir, some common myths जो लोगों को लगता है ये ऐसा होगा ये ऐसा नहीं है, that you get to deal with, and बस some myths की लोगों को पता तो चले.
It's a very very good topic, and I'd like to share. Simple, starting from asthma. People have a myth that I don't have asthma.
मुझे कुछ हुआ ही नहीं.
Right. मुझे तो सिर्फ खांसी हुई थी. मुझे कुछ अस्थमा है नहीं. First myth starts from there. Second myth, I do had asthma in childhood. मला बाल दमा होता. आता नाही आहे. बाळ दमा आहे, आता नाही आहे. अरे नाही, तेव्हा होता तर आताही probability आहे. If at all, I tell you that you have an asthma, they get a shock. Oh, no, I can't. They are in denial. They are in denial. Second thing, after denial, if I prescribe then inhalers, they are what is this inhaler? अरे ये तो addictive है. ये तो इसमें तो steroid है. Steroids are bad. Boss,
तो इतना demonize करके रखा है steroids.
Steroids are not bad.
They are not bad.
Treating asthma with steroid is a protocol. And there is a scientific evidence which suggests that inhalation corticosteroids does reduce your asthma, and it has got very, very minimal side effects as compared to the oral steroids.
Definitely.
So, and second thing myth is it is addictive. No, boss, it's not addictive. It's a treatment. If you don't take inhalers, if prescribed, it is certainly going to reduce your lung health. It is certainly going to reduce your lifespan. It's scientifically proven. You are playing with your life. And third most important myth, which most common myth which I come across is I had asthma, I treated it, now I don't need to continue any medicine. See, there are 3 categories of asthma: mild, moderate, severe. If you are in moderate and severe category of asthma, certainly you require medicine, a maintenance dose for life. There is no running away from it.
Right.
So if you are not dealing with it, you are certainly doing harm to yourself.
We are almost at the closing answer. What are some key takeaways that you would like to tell people who are going to watch this podcast about lungs and everything? Meditation, pranayama, does that help?
Yes, certainly. Overall health of a lung depends on 3 or 4 factors. First is lifestyle. Quit smoking if you are. Relocate yourself from a polluted area if you can. Third thing, exercise daily. Fourth thing, get yourself immunized. Get vaccinated basically for pneumococcal and influenza. Fifth most condition is you need to get yourself checked up. It's a simple thing, very, very cheap to get your lung checked, but go ahead, do that check yourself. And fourth is doing lung exercise. Lung exercise can be any format. It can be yoga, it can be meditation, it can be simple physiotherapy exercises. But the moment you do all these kind of exercises, it is certainly benefits you. It's an attitude thing. And primarily focus on your lung health. Why? I'm telling you, it's the most underrated thing to do in India. People will do their ophthalmic checkup. People will do their bone density checkup.
Right.
Bone density checkup. Their liver, they check it. Their cholesterol, they will check. Sugars, they will check it. They will check their ECGs, 2D echoes, and a number of things. But they won't check their lungs. So I suggest each and every one of your viewers to go ahead and do their lung test.
Thank you, Dr. Parimal, for being here. If you have any questions, you can just put it down there in the comment section. I'm sure Sir will answer. Sir is available at KRIMS Hospital for a consultation if you need. Thank you, sir, for being here.
Thank you.
I hope you had fun.
I had fun, and it was my privilege to come out to your studio and get myself do a podcast with you. I hope you will invite me.
Yes. So probably next we can just pick one topic and we'll do a deep dive into one. Let's say you said asthma खूब मोटा topic है. We'll just choose one topic as asthma and पूरा घुस जाएंगे उसमें एक time.
बिल्कुल 100%.
Thank you, sir, for being here. Thank you.